Okay. Uh, we are live on the YouTube now. Good morning, all. Welcome back to Saturday Club morning meeting. And before we have our academic session, we would like to pay our tribute to our great legendary Dr. Vaishnav sir. He was part and parcel of Saturday Club from its beginning. And we all have known him as an astute clinician, a great human being, a pursuer of academic excellence. And in our Saturday Club group also, many of us have actually poured in our emotions and our impressions about Dr. Vaishnav sir. So today, before we continue with our academic session, I think which was his spirit, academic excellence. So, we have not cancelled this meeting for paying tribute to him. I believe, and many of our colleagues in Saturday Club believe that the right tribute to a person like Dr. Vaishnav sir would be to continue the academic pursuit that we are all doing with our Saturday Club meeting. So we will devote some 10-15 minutes for all of us to pay our tribute to Dr. Vaishnav sir. So I request first Dr. Satish Shah sir to give his feelings about Vaishnav sir's departure from us.
Good morning, everybody.
Good.
I will tell you something about my relations with Dr. Girish Vaishnav. My real contact with him started in 1967. We started the CME club with 3 people in Nawabara. Then we all moved to Samir building, and myself and Vaishnav started our practice there. Our daily contact improved in Samir building. This Saturday meeting is unique in whole of Baroda and maybe in Ahmedabad and Surat. Our contact with Dr. Vaishnav increased in this Saturday meeting. Saturday meetings are unique and it is continued for last 53 years. Dr. Vaishnav was a voracious reader. His tragic health problem is well known to you. I thank you all for patient hearing. We all pray to God for bearing this loss. I again thank you, all of you, for patient hearing. Thank you.
Thank you, sir. Thank you. Daksha Ben?
Yeah, actually, most of you know that in the beginning, I was practicing in Samir building first floor, myself and Satish, and Vaishnav Sahib, he was on the second floor. So in the beginning of practice, whenever I had some diagnostic problem or something, I used to run to him, and then we try to solve the problem and all that. Now, secondly, I learned from him was how to talk with the patient and patient's relatives just by observation. And I learned a lot from him, the other things other than medicine, especially how to talk with the patient and all. Another thing, Dr. Vaishnav was so close to Satish. Probably most of you might not be knowing that. Hello.
I request others to mute your speakers, please. Yes.
Most of you may not be knowing that simultaneously with the Saturday Club, every Thursday, that meeting was Sanskrit meeting was started at our home in Vishwas Colony, and it was Dr. Vaishnav who supported Satish for this meeting. And 10 to 12 people, they used to come to our place. There was one teacher who was coming from Ahmedabad, and Dr. Vaishnav used to pick up him from the railway station at night at around 8 o'clock. In such a busy practice, for 50 years he did that work, and that most of you might not be knowing that. And that meeting was continued up to, I would say, up to COVID started. So it was a continuous, very good support to Satish by Dr. Vaishnav. Another thing, he was very much fond of movies. We always used to go together to see movies. Whenever we had any medical problem in the family, either to me or to Satish or to children, he was the one who always supported us. He was more than family for us. And same is true for Mrs. Vaishnav Uma Ben. Same is true for Anand, Radhika, Mona, everybody. They are like family to us. And, we will remember him forever.
Thank you, Dakshaben. We all understand the loss that we all feel, but the most with you as a couple, because I have always seen Vaishnav sir and Satish bhai together in whatever academic activities or other things that they were all doing together. So we understand the loss. Thank you, Dakshaben, for sharing your feelings. We acknowledge presence of Vaishnav Sahib's family here. Mona is there, Dr. Anand is there, Dr. Radhika is there. So to the family, on behalf of Saturday Club, we express our heartfelt loss of Vaishnav sir, and we are all with you in your grief. Now I request Jagdish bhai to express his feelings.
Thank you, Satish bhai. For Kokila and me, Dr. Vaishnav was Girish bhai, always, because we knew him before he became Dr. Vaishnav. We were together from first year of medical college. He was just 1 year senior. His batch was of only 40, our batch was 60 only. So we had close companionship during undergraduate and postgraduate studies, during residencies also. Afterwards, we started having a stint at medical college in physiology department, where Dr. C.J. Shah, myself and Dr. Vaishnav worked as a part-time teachers, and we worked together in physiology department. We used to visit district places to give talks to the Indian Medical Association at different places like Bodeli, Chota Udaipur, Dahod, Khambat. At all places we used to go there. He would talk about medical aspect, I would talk about surgical aspect, Dr. Amin would talk about pathology, etc. When we started our practice also, our clinics were close by. So we had very close association that way also. He had brilliant academic career. Even while he was resident, patients had started loving him. And no sooner he started his private practice, it grew so fast that in few years, it was difficult to get his appointment also. However, for every difficult and cases which were not easy to solve, Dr. Vaishnav was referred those cases. He was avid reader and used to attend regularly conferences. He was always sought after a speaker at different conferences. He loved outings, he loved cinema, he loved good food. He was devoted family man. He raised 2 brilliant children who are gift to city of Baroda. He lived very happy life. For him, money was a fringe benefit of good and noble work he did. His brilliant life lived with happiness, his best legacy he has left for all of us to cherish and remember him. Thank you.
Thank you, Jagdish bhai. May I request Dr. Suresh Amin Sahib to say something, some words? Sir,
Please mute.
અમારું સંભળાતું નથી સર અમીન સાહેબ.
Mute Shemna phone.
Okay, I will. અમીન સાહેબ તમારું મ્યુટ લાગે છે. હા.
Yeah.
Yes.
મારો અવાજ ભારે છે. Anyway, Vaishnav was a couple of years junior to me, and whenever we used to have exams together, I used to tell, have you read this in presence of somebody? And he would go to the library and start reading. It was an exam prank on my part. I attended his marriage also. And Basically, he is very, very curious on many aspects. And we have toured together many countries. And there, everywhere, he was very curious about everything. So his curiosity was this one. And most important, that he always felt that there is a teaching association, and there should be a honorary system in medical colleges, so that he can contribute by giving their own affairs. Anyway, thank you very much for giving me the opportunity to share.
Thank you, sir. Thank you. We have Dr. V.R. Patel with us. Sir, would you like to say something?
Yes, sir. He was very much near to me. He was my friend, philosopher and guide. One day in the morning, just he told me, "Ke savare શું કરે છે?" મેં કીધું કંઈ નહીં. So why don't you join our Saturday meeting? Then I used to join our Saturday meeting, and then I used to sit in his clinic also, and in physiology also we were together, because I was full-timer at that time, and then I became part-timer. He was part-timer. He was our teacher, and then he became my colleague. When I was appearing for ECUMG, he said, "Susu watch," and I was given my complete room, and then Dr. Mazumdar was there. So we have great memories with me. He used to come to my place. I used to go to his place. Umaben and my Mrs. Nalin, they used to prepare the food also together. We had gone to villages also many times. It's always nice. Vasant Bhai and Sahib used to come to my place for dinner also. Sometimes they come in lunch also. So anytime, anything, something, lot of problems are there with my patient. So I go there and say, call the patient, or you just narrate me the history. Many of my patients, when I tell them that Dr. Vasant and this Vaishnav Sahib is not there, and they go into the shock, and hardly means this is how na hoy, and they sit on our waiting room, and then I just counsel them. So a lot of memories like that. Please, thank you. I cannot end.
Thank you, Vinod bhai. We understand how close you were to Dr. Vaishnav sir, and a lot of your medical learnings were from him. You used to share during our Saturday club meeting everything about your relationship with Vaishnav sahib. We have Tushar Chokshi. Tushar, are you there?
Yes, sir.
Yes.
વૈષ્ણવ સાહેબ માટે શું કેવું? હું એમની જોડે તો આમ તો મોના જ્યારે મારથી 1 વર્ષ આગળ હતી, અને અમે એના ઘર પાસેથી સાયકલ લઈને એલએનવી સ્કૂલે જઈએ ત્યારે ઓલવેઝ અમે એમનું ઘર જોઈએ. અને જ્યારે હું સતીશભાઈ જોડે 1982 થી ફર્સ્ટ MBBS થી જ્યારે હું સમીર બિલ્ડિંગમાં જોડાયો, ત્યારથી જ હું વૈષ્ણવ સાહેબને જોતા આવ્યો. અને મને ખબર છે કે કોઈ પણ પાયરેક્સિયા અનનોન ઓરિજિનનું પેશન્ટ હોય તો હંમેશા લોકો વૈષ્ણવ સાહેબને જ યાદ કરે. અને એમની પ્રેક્ટિસની જે સ્ટાન્ડર્ડ ક્વોલિટી હતી એ જોઈને હું બહુ ખુશ થતો. અને મને એટલું પણ યાદ છે કે જ્યારે પણ મધ્યપ્રદેશથી કે કોઈ પણ જગ્યાએથી પેશન્ટ આવે તો એમને કોઈ પણ જાતનો પ્રોબ્લેમ હોય તો એક જ વસ્તુ કે સમીર બિલ્ડિંગ, ડોક્ટર વૈષ્ણવ ઓર ડોક્ટર સતીશ શાહ. દેટ વોઝ ધ ફેમસિટી ઓફ ડોક્ટર વૈષ્ણવ સાહેબ એન્ડ હિઝ ટીમ. અને બીજું તો શું કહેવું, કારણ કે હું તો એમની પાસેથી ઘણું શીખ્યો છું, પણ છેલ્લા 15 વર્ષ દરમિયાન જ્યારે પણ કંઈ એનેસ્થેસિયાને લગતું એમને કંઈ નોલેજ જોયું તો તે મને ખાસ પૂછતા, અને ઘણીવાર તો ફોન પણ કરતા. હું એમની જોડે છેલ્લા 15 વર્ષમાં ભાગીદાર હતો. અને અમારા જ્યારે પ્રી ઓપરેટિવ ફિઝિશિયન્સ તરીકે અમારા TURPના પેશન્ટમાં આવે, સતીશભાઈ જ્યારે ઓપરેશન કરે ત્યારે મારી જોડે ખૂબ જ ડિસ્કસ કરતા, અને એમની પાસેથી હું ખૂબ જ શીખ્યો છું. અને એમના જેવો ફિઝિશિયન આજ સુધી મેં કોઈ જે ફાધરલી બિહેવિયર હતા. થેન્ક યુ સર.
Thank you, Tushar. Rumin, are you there? You want to say something? I know there are many people in Baroda who are, not formal students of Vaishnav Sahib, but sort of Eklavyas. Like I was never in medicine. So as a pediatrician, I have learned from him by remotely watching him, the way he used to treat my close relatives who are his very chronic patients. Then we started interacting on academic matters. And the most important thing was that he was very easily approachable and a very humble person. In spite of all his greatness, and known as a very great physician, very sought after physician, it was very easy to approach him. And as Dr. Tushar said, he had a lot of hunger for knowledge every time. So he wouldn't mind asking me certain questions which he would like to know as far as pediatrics is concerned. So there are so many Eklavyas in Baroda and across Gujarat who have learned a lot of things remotely from Dr. Vaishnav Sahib. Yes, Rumin, please.
A lot of physicians and doctors of my generation or our generation have learned the nuances of medicine from him. But for him, we wouldn't have known the principles of getting completely updated every now and then, making efforts for going to learn extra mile walk to learn newer things. He was a very compassionate physician, very caring physician, extremely punctual, and in all difficult cases, he was always there to stand with us, help us. And despite his great success in academics, in practice, he lived a frugal life, which actually is a lesson to us. And I think the true, the way we should remember him is by devoting ourselves more and more to our patients, by accepting newer things, learning newer things, and being humble. Thank you.
Thank you, Dr. Rumin, for those comments. We have Dr. Kiran sir. Kiran bhai, would you like to say something?
Okay. સૌથી પહેલામાં તો એમને શ્રદ્ધાંજલિ પહેલી અને નો ડાઉટ એ મારા ગુરુ જેવા જ હતા. એમની પાસેથી ઘણું બધું અત્યારે પોતે જ હતા. સેટરડે ક્લબનું એક મારું સ્મરણ છે અત્યારે. અને ખરેખર એમની જે જ્ઞાન પીપાસા કહીએ ને કે જ્ઞાનમના નવી વ્યક્તિ પાસેથી પણ જે લર્નિંગ એમની પોતાને પૂરી જિંદગી એ એક આપણે બધાએ ખરેખર શીખવા માટે છે. બીજું તો કઈ વધારે.
Thank you, Kiran bhai. Dr. Hemant sir. Meanwhile, Praveen bhai would.
Good morning.
Yes, Hemant. Yes.
Satish bhai, since 1985 when we were interns, we found out there is only one place to learn all the aspects of practice, and that is in the umbrella of Dr. Satish Shah's clinic, where Dr. Vaishnav, Dr. Vasant Patel, and all the people who were, as he tells, Jnana Pipasa, he established in Baroda that academic excellence can transform into good private practice. And we will all remember him and always salute his spirit. It should go to the generation next also. Om Shanti.
Thank you, Anand. Praveen bhai. સાહેબ તમારું અનમ્યુટ કરી દો પ્રવીણભાઈ, પ્લીઝ અનમ્યુટ. યસ. નહીં, નથી સંભળાતું. પ્રવીણભાઈ, યુ પ્લીઝ અનમ્યુટ યોર સ્પીકર. So while he is trying to establish connection, if anybody wants to say something or express his feeling, you are welcome.
કિરણ દલાલ હોય તો છે.
હા સાહેબ, દેખાતા નથી મને. જે દેખાયા બધાનું
ચેતન શાહ.
યસ સર, ચેતન.
ચેતન, yes, Chetan.
In fact, I was one of the very close associate of Vaishnav Sahib. He was my teacher as well as my guru, both. And I think most of the things have been told by Satish bhai and Amin sir and everybody. One or two more things which I would like to add was about his punctuality in time. Like, the chemist who was downstairs in our Samir building, he used to say, Sahib aave, એટલે આપણે 3 વાગ્યાનો time match કરી દેવાનો. Sahib aave, એટલે સવારે 9 વાગ્યાનો time match કરી દેવાનો. That punctual he was. That was his wonderful. Another thing was he himself was definitely very keen for academic this thing, but he used to make others also inclined to that. Like અમને લોકોને પૂછે કે તમે આ NEJM વાંચ્યું, તમે આ લેન્સેટમાં આર્ટિકલ વાંચ્યો, તમે પછી અમને એવું બી કે start attending this, like, the way I started attending Tuesday meeting, Thursday meeting, and Saturday meeting was due to him only. He suggested that tamare I meeting attend karvi જોઈએ. And not only to me, all of us who were with him, he used to tell us that you should attend this meeting. So these were some of the qualities. And another thing was, he would always share his this thing. Any difficult patient, he would say, the next day he would tell us that I saw yesterday this patient, it was like this. What do you think? And then he would also share his this thing that, look, I managed him like this. This was his diagnosis. So these were some of the things. In short, I would like to say that he could set a benchmark which probably all the future generation would try to achieve that goal. Om Shanti.
Thank you, Chetan. In fact,
Satish
I
bhai,
started
Dr.
going
Samita
to
Amin છે.
Medical College Library after knowing that Vaishnav sir used to go to Medical College Library every Thursday or about a couple of days in a week. So I also emulated him and started going to library, and I used to close my OPD every afternoon on Thursdays. So that's the kind of learning that we all had.
That was one day, one for me as well. Like, I had kept Wednesday afternoon off, and I used to go to Medical College Library. Subsequently, Medical College Library, we used to go, me and Vaishnav Sahib, to Sarabhai Library and Alembic Library. So that was another thing, yes.
Dr. Sancheti, you there?
સતીશ ભાઈ, ડોક્ટર સમિતાબેન અમીન છે.
Samita madam, please.
Bolo.
Madam, if you want to say a few words.
Public platform માં તો હું બોલવા ટેવાયેલી નથી. But I have no words to describe or whatever relationship I had with him. It was just, I don't think any one of you will understand, because I was never in private practice or anything like that. My association with him was entirely on a different platform. And on telephone or whenever we used to meet, I had attended so many conferences with him all over India, and just, what more can I say? Thank you.
Now, we request Vaishnav sir's family members like Dr. Mona or Dr. Anand or Radhika, if you want to express your feelings.
Anand, I think first of all, I have nothing more to say. I think eklavya was the right word. But I'll just say 2 or 3 things that if I have to describe it, I think the passion for it. So I think what I tell people, I'm probably 100th of him. Je pan karo, passion thi karo, prem thi karo. I think ઘણીવાર do it for the love of it. આપણે ઘણીવાર ભગવદ ગીતામાં લખ્યું છે કે કરો ને ફળની આશા ન રાખો, but how many of us follow it? So I think that's one thing. And my 2-3 small memories are, હું નાનો હતો 6-7-8 વર્ષનો, ત્યાંથી I remember New England Journal Medicine lying in the corner, અમારા દરવાજામાંથી enter થઈએ. And for those of you who know Mayo Clinic and Olmsted County, મને હું નાનો 6-7-8-10, I don't know exactly, I knew what Olmsted County was. I thought must be a big city in US, New York or something like that. That was Olmsted County was Mayo Clinic. So I think passion. I think go for it. I think that's what I tell. I think તમે બધા તમારા વડીલ થાઓ. But I think that's one thing I learned for it. Try to be honest to yourself. And I thank you all.
Thank you, Anand. Mona, would you like to say?
બોલો.
Okay.
Sorry. Sorry, thank you so much for being here. Papa was my mentor, friend, philosopher, and guide. I learned what is passion, what is compassion, what is persistence, and what is evolution. Everything from him. He's been, and during this time, I realized that I'm not only
we're not only three of his children. He has so many brothers and sisters, and he's guru to so many of us. I've learned so many things, and I don't grieve on and talk that he's no more. I miss feeling now that he's with us, amongst us, and in our heart, and he'll ever be with us with his blessings, his being role model, his inspiration to not only me but to many of us. And thank you so much for being with us and make us feel that this is the way. Thank you, Satish Bhai, and thanks everyone for organizing this.
Thank you, Mona. The whole Saturday Club family is always with Vaishnav sir's family. Radhika, would you like to, because you have been the very active part of Saturday Club since it has started online. So would you like
So I'm actually going to give a personal small anecdote because everything has been said here. I think, but going on when he used to come to US to visit us, my participation was to take him to the library. So we would actually, he would always want to come down in the morning, and so he would come with us to the university, and then he would sit for the whole day in our university library there. If it was for 1 month, then for 1 month, every day he would come, he would sit in the library. In between, I would come and get him. He would come with me for lunch, get a sandwich or something. Again, go back to the library. I would say, when you are ready to go home, I'll take you home. So just wanted to share that passion he has transferred to all of us, and the only thing that we know is to carry that forward, and that's, we do not understand it. So thank you. And I'm very happy to see that this legacy is being carried forward in whatever way everyone sees best. Thank you.
Thank you. Thank you. So at this juncture, we end this Shraddhanjali meeting. Those who have been left out, who could not express here, please put in your messages in our WhatsApp group of Saturday Club. For a week, we will continue to accept these messages. After that, we'll again go back to our very strict pattern of not giving any personal messages. So for 1 week, we'll dedicate this week to Dr. Vaishnav sir. So those who are part of Saturday Club, please express yourself in the WhatsApp group. So we end this prayer meeting here by observing a half a minute of silence, and then we'll start our academic week. Om Shanti. Thank you. Jai Shri Krishna. So we observe a silence for few seconds. Thank you. Om Shanti. Now, as I said, we must continue the good work of academic excellence that we have been pursuing since so many years. So we start our routine Saturday Club morning meeting here. Today we have Dr. Jaimin Jaisalpura, an orthopedic surgeon from Baroda. His areas of special interest are arthroscopy, sports injury, joint replacement. He worked as associate professor at SSG Hospital, Vadodara. He did his fellowship in various expertise of orthopedics from South Korea, UK, and India. And he is currently director of Vaishvi Hospital. So Dr. Jaimin will be talking to us about recent advances in management of shoulder pathology. Over to you, Dr. Jaimin.
Thank you, Satish. First of all, just sharing one experience with doctor. I am taking this opportunity and take 1 or 2 minutes of all of us. His family member and their friends and senior doctors of Baroda. Good morning, and we shared a good memory about his academic excellence and the passion which he left behind, and the tradition of sharing knowledge on this platform. So when I I was working with the government till 2012. And when I came back to Baroda in private practice, so I had my first talk, I know if I remember, on the frozen shoulder at Bailal Amin Hospital. And one of my senior colleagues told me that, Jamin, Dr. Vaishnav is going to interact with you. He is going to ask you few questions. So be ready for that. So, you know, that was, I was pleased that getting so much of interest out of the field, your own field, and such a curiosity. And we had a good interaction thereafter. So with this memory of my first talk, when I came into the private practice, leaving my academic field. So we'll move on, Satish Bhai, with today's presentation. Thank you. I think slides are visible on screen.
Yes, very well.
So our today's topic is regarding the recent advances in the management of shoulder pathology. Just give me a minute. So usually a shoulder is a joint where your history and clinical examination plays a very big role. Because as an orthopedician, we are usually concerned with either end-stage arthritis, or we used to look at a lot of trauma cases, fracture cases initially. So this is more, shoulder joint is more on the balancing and soft tissue problems. And that's why it is very challenging to diagnose shoulder pain and the pathology and to treat it. So usually we have got two spectrums. One is a younger age group who is having shoulder pain, maybe due to trauma, sports injury, and the elderly age group where the patient is suffering from diabetes, thyroid, or arthritis related issue, inflammatory disorder. So these are the two spectrums as a clinician we see in our OPD practice. So if we let us go to the basic of anatomy. So when we see, it's a ball and socket variety of joint where you have got, it's been balanced with the help of rotator cuff tendons, rotator capsule, and you have got a subacromion bursa. So movement of your shoulder joint is depend on the balancing of the rotator cuff muscle, and the stability is being provided by capsular ligament structure and the glenoid labrum part. So what are the common shoulder problems? What we see in our OPD practice is, first is a frozen shoulder. But frozen shoulder is, I would say, a very broad terminology, and there are a lot of diagnoses are hidden. It's just, I would say, a tip of an iceberg. What we call is a frozen shoulder or periarthritis shoulder. There are going to be a lot of, it's like a pyrexia of unknown origin for our understanding. So we'll go in the detail in the next slide. But when the patient presents to us in our OPD, it could be a frozen shoulder, could be weakness of the shoulder. Patient might have experienced previous injury, and because of that recurrent shoulder dislocation, there could be local swelling, arthritis. Because of history, patient might have suffered from fracture, and there could be a previous history of surgery and patient is not doing well. So these are very common shoulder problems what we encounter in our clinic. So one of the most important concept in the shoulder joint, as I told you, it's a ball and socket variety of joint, and it's one of the most mobile joint where you have got a 360-degree range of motion. So what I mean by a force couple? A force couple is a two equal forces which are acting in opposite direction to rotate a part about its axis of motion. So now this force couple. So here, if we see in coronal section, it is your deltoid and the supraspinatus are going to work as a force couple, and balancing between these two muscles are going to keep your joint reaction forces in the center of the joint. The same way, if you see in a coronal plane, it is subscapularis anteriorly and the infraspinous posteriorly. So this is going to act as a force couple. Now, all these four muscles, the health of this rotator cuff, anteriorly subscapularis, your supraspinatus, infraspinatus, and teres minor. The more these four muscles are balanced, healthy, the patient is not going to have any shoulder issues, a normal healthy patient. Because what happens, the moment your shoulder rotator cuff becomes unstable, your humeral head is going to migrate proximally, and then it will impinge on the acromion. And there are a lot of structures between the humeral head and the acromion. Longered up biceps, capsule, your bursa, your tendons, your undersurface of the joint. So the moment your rotator cuff becomes unhealthy, there will be a proximal migration of the shoulder, and patient will come to the clinician with the shoulder pain. And one of the very commonest complaint we hear from all of our patients is their inability to sleep on the same side. It's a very common complaint. Many of them will not notice the loss of range of motion because shoulder is a very highly mobile joint and you compensate at a scapulothoracic joint. So when they reach to us, they might have lost more than 50% of their range of motion if we examine them. So when we take our arm in the air, what happens? Gradually, when we take our arm, your shoulder gets abducted and externally rotated. And that's how we clear up our subacromion space. And your scapula, along with the humeral head, is going to help us out to clear the subacromion space. So it goes into our scapula goes in the retraction and elevation along with your shoulder as you act up to 90 degree to 120 to 180 degree in a forward flexion. So scapula, it provides an anchor and it follows the humerus to get our arm into the space. So having understood this basic science of mobility of the shoulder joint and the stability part, let us go what happens, how to diagnose the clinical condition behind the shoulder pain. So you can't have impingement, you can have a frozen shoulder if your movements are restricted in all directions. That is a forward flexion, your rotations, going back to your shoulder, combing the hair. So these are all different routine activities where you need a good rotational movement, combing the hair, going back to your shoulder joint, wearing the seat belt. So these are all common questions we ask the patient that to know their range of motion. Whenever patient is having trivial trauma beyond the 50 years of age, and then they will say that I have difficulty in getting objects from the shelf. So your overhead activity is going to be slightly restricted and patient will feel the weakness and pain along with that. And when patient is having wrist pain, that is the time when we consider some of the inflammatory disease, or it could be an arthritis as well. Again, shoulder being a non-weight bearing joint, like arthritis of knee, here in arthritis of shoulder, patient presents a bit late to doctor. So consider that every patient which comes to us in clinic and we diagnose them as a frozen shoulder or periarthritis shoulder. So how to just examine them? So when we always say them, you get your active forward flexion, you get the rotation, go in a throwing position, you take your arm back and touch your fingers right? So this will give you rough idea of total range of motion. If the patient is having both active and passive range of motion restricted, when patient is doing and the clinician is examining, and both are restricted equally, then yes, patient is having a frozen shoulder where only the capsule of the shoulder joint is quite thickened and tightened and inflamed. And because of that, patient is in severe pain and with restriction of movement. So it could be idiopathic, and we see post-traumatic, and we see a lot of diabetic patient. So diabetic frozen shoulder is one of the worst condition what we have seen more than 10-15 years in shoulder practice to manage, because it's very, very painful. So when it is developed following trauma, we need to find out whether there is any other injury to the rotator cuff, or if it is non-traumatic, then usually we get done few investigations to see calcific tendinitis. You can always see on X-ray the calcium deposit. You can always find out early osteoarthritis, impingement or biceps tendinopathies on your sonography or on MRI. Now, patient is not able to take his arm in the air, but when the clinician examines it and he is able to do full range of motion, that means there is a weakness in the right shoulder joint. What we observed in a patient of, post-paralysis, where the patient is not able to actively move the arm, but the clinician, if he wants to, he can carry out all the movement. So if it is so, in those cases, it could be the rotator cuff tear, it could be neuropathy, it could be deltoid paralysis because of your axillary nerve palsy. It might be generating from the cervical neuropathy. Someone who is having cervical disc issues and compression of your nerves, and because of that, they are losing the power. You can always rule out any kind of infection or tumor in the shoulder joint when the pain is severely painful, local condition shows inflammation, redness, and you need to go ahead with your blood markers. When patient is in both active and passive ROM restricted, and on X-ray you are able to find out there is a osteoarthritis, or many of the patients who are having convulsions, seizures. So, and if those patients are neglected post-seizure, they will have locked dislocations. So the shoulder gets dislocated and locked behind the glenoid. There is a locked posterior shoulder dislocation. So these are the few conditions which we would like to diagnose with the help of X-ray, sonography, MRI, and blood investigation. So when we take an X-ray, it has to be true APV like this.
Yeah.
We need to explain our radiologist that I need a true APV of the shoulder so I can visualize the shoulder joint nicely. At the same time, the axial Y view. This is scapular Y view. You can see this Y view. So this is going to give us the good idea of the subacromial space. So if there is some bony spur or a calcification, we will be able to pick out. So whenever we ask for the X-rays, it has to be a true AP view and scapular Y view or outlet view to diagnose any shoulder condition.
एक मिनट sir. So
if we go in the X-ray, so you can find out the dislocations, fractures, rotator cuff tear. You can predict it because if you see here, your shoulder humeral head has migrated proximally, it is touching the acromion. So there might be a tear of the rotator cuff, it has retracted and your shoulder is directly abutting the acromion. And in the end, arthritis of the shoulder joint. So these are very common few conditions. When we ask for an X-ray, we can diagnose in our OPD. So usually nowadays we do a lot of CT scan and MRI for shoulder patients, sonography particularly to diagnose in emergency calcific tendinitis, bicipital inflammations. Why I have mentioned the blood glucose level, we always check past history of diabetes in the family. Many a times we get an FBS, PP2BS and HbA1c at least in all of our patients to check they are not diabetic. because in shoulder management, diabetes plays a big role. And hematological and biochemical test when the patient has underwent for any previous intra-articular injection of steroids or something. So whenever we treat these patients, our primary goal is to relieve the pain, restore the movement, and to regain the function. So these are the three commonest things what we would like to do our patients. So how we manage? Majority of the cases when the patient has not suffered a fracture or not a major injury, we usually prescribe them, ice pack or hot pack, give them NSAIDs, and once they are relatively pain-free, we ask them to go ahead with the shoulder rehab, that is a shoulder physiotherapy. Many of the cases we go with the intra-articular steroids. However, I use it very infrequently, maybe 2 or 3 in a year. So it depends on the conceptualization of orthopedic surgeon, how much they want to give intra-articular or subacromion or oral steroids. And MUGA, that is a manipulation under general anesthesia, which was a very routine practice. And I have rarely done in my practice any kind of manipulation because of different reasons. So having said that, this is a brief ideology how to investigate these patients as per their age group, as per their history of trauma, diabetes, or previous surgery, and what are the management aims in our patient for the shoulder pain. So if we go for the frozen shoulder, what are the different line of managements which are available? If the patient is not improving with the physiotherapy, we can put an intra-articular steroid in the shoulder joint. Someone can do manipulation, as I described, I personally have not done, or you can do arthroscopic release as well. So what we do, there is first is we always explain our patient, we counsel them that you need to go with the physiotherapy not less than 4 to 6 months, because it's not going to, frozen shoulder is not going to respond immediately. Initially, when we start with the physiotherapy, patient is going to be more in pain. We need to be very supportive with cold packs, different modality of pain management and counseling. Now, if the patient is not improving, we always ask them to go ahead with the hydrodilatation. Now, what do we mean by hydrodilatation? So we put a needle under IITV guidance inside the shoulder joint, and you are pouring water in the balloon and the balloon gets expanded. The same way we push distilled water along with that Kenacort and Sensocaine in the shoulder joint and we balloon it out. So the aim is to stretching out of the capsule and breaking the adhesions. And these patients does well. It's just a procedure where patient doesn't need to remain admitted overnight. So that's the hydrodilatation is a very good procedure which we can offer to all our frozen shoulder patients who are not improving and in so much of pain. When we do an arthroscopy, yes, if the patient is not improving by all this modality of management, and MRI does show that the capsule is very thickened and it is not amenable to stretch. And when the patient demands, usually we go with the arthroscopic frozen shoulder release. Just a minute. So here is a brief video on it. Excuse me, it seems that it's not working. So let me try once. Excuse me. So Satish bhai might be, let me go ahead.
Yes, if you have that clip in the other folder, you can try that. How
Yes.
much time you want still more? Because today we had little curtailed meeting.
Yes, sure.
So no, if you have more extensive coverage to make, we can have part 2 also. I mean, I leave it to you.
Yeah, I
So-
feel okay. So let me, I think we are just 10 minutes short to 9. So let me go. I will avoid all the videos and I will just go on brief on the major part of our shoulder management, right? So let me avoid it thankfully. Yeah. So another thing, subacromial impingement. These are all I am talking about the operative indications when patients are not improving with the physiotherapy. So in shoulder, in cold cases, physiotherapy plays a very good role here. So if you can see here the spur. So again, you go arthroscopically and remove this spur, clear this space, and patient can get pain-free. So that's how you can see a nice tendon. There's a part of tendinosis here. And whenever there is a spur, we can see at the level of acromioclavicular joint or at the edge of the acromion. So I'm avoiding any of the videos. So the commonest injury beyond the 50-55 years of age we see is a rotator cuff tendon tear here, right? So when we see the shoulder, your supraspinatus is one which keeps your arm above the shoulder along with the deltoid, your infra teres minor which will rotate it externally, and your subscapularis anteriorly which rotate your shoulder in the internal direction. So balance between these four structures, as we have discussed, is very important. And the commonest what we see in our patient is rotator cuff tear. So if I am operating 10 arthroscopic shoulder surgeries, I am operating almost 7 cases of this rotator cuff tear beyond the age of 55-60. So how we do it? We go arthroscopically. If it is retracted, we bring this tendon back to its original position, and that's how we examine. Ask the patient to do thumb down and ask them to resist against your power. Ask them to take their shoulder up. And if they are not able to do it post-traumatically, they are having some or other rotator cuff tear, which we can very well pick up on MRI. So that's how we do it. We put a screw, we can do single row, double row. That's how it looks in the X-ray. And we bring back this tendon on the humeral head to stitch it. And this gets healed over a period of 6 weeks to 3 months. So that's how we do it. It's all arthroscopic surgery. Hardly take 4 stitches of 4 to 6 millimeters. You have got arthroscopic trolley along with that. And we usually do it in a Bichir position and under general anesthesia. So that's your rotator cuff tendon. That's the anchor what goes in the bone. And these are the threads with which we bring this back and we tie the knots. So if you can see, we can close down this gap and this tendon comes in direct contact with the bone and it gets healed over a period of time. I will be skipping these videos. So what are the advances? As I told you, yes, rotator cuff repair was done since years together by open method. Since last more than 12 years, we all are doing arthroscopically very regularly. But there are challenging cases where 55 years, 50 years of age, if you see the rotator cuff is here, it is no more repairable. Now 50 years of age, you cannot offer replacements. So we bring the long head of biceps in and we reroute it. So if you see here, this is a long head of biceps. Usually it lies anteriorly in your shoulder joint, right? It lies anteriorly. So we bring it arthroscopically in the posterior direction, in the direction of rotator cuff, and we fix it over here. So when you do that, what it does, this long head of biceps, we bring it back. It depresses the humeral head. So as your rest of your rotator cuff muscles work on it, right? So again, not going through the videos, this patient does well because at the age of, they are too young patient to go with the reverse shoulder arthritic replacement, and you cannot leave them alone because they need function. So there are different methods. We even take fascia lata from the thigh. You harvest the fascia lata and you put it onto the glenoid. Here, you harvest the fascia lata, you put it at the glenoid and the humeral head like this long head of biceps, and you cover it this space and avoid this proximal migration of the humeral head and touching the correct, your acromion. So there are many different methods to cover it up. Satish bhai? Hello? Yeah.
Bolo. Yes.
So this was all regarding the part of the only rotator cuff and elderly patients problem, like a frozen shoulder, rotator cuff tear, inability to lift the shoulder, younger age group. So the next two parts are more on the instability and the replacement. So I feel that today, if we can have a few question answer and we can just shift on maybe on next
We'll
week.
keep a part 2. Whenever these things happen, when we are not able to cover everything in a given time frame, we have it as a part 2. So we can have it in the month of May as per or whichever date is convenient to you. We can have it.
Perfect.
So
So-
today we stop here. You can stop the screen sharing, and whatever you have covered, we can have questions about it.
Perfect.
And we'll
Perfect.
plan another meeting on the same subject. Whatever is remaining, we'll take up during that meeting.
Sure.
Thank you, Jamin bhai. That was very lucid and very simplified for a complex subject like shoulder pathology. In the chat box, I see one question from Dr. Gopal Agarwal, and that is about prevention of frozen shoulder tips.
Yes. So as we have discussed, shoulder is having a highest range of motion. That is 360-degree range of motion. You can even rotate in all the direction. So once we lost the movement, you never come to know till you lost 40-50% range of motion. So after the age of, I would say 55-60, particularly if you have a history of diabetes, you need to visit your physiotherapist regularly. Yeah, because your arm, you should be able to go back of your head and back of your elbow. You see, your tip of the finger should reach here till C7 vertebra, spinous process. So if you are not able to do so, then yes, rehab is one of the first thing we would like to get in. And for diabetic patients, I would advise to consult a shoulder surgeon at least once in 6 months. Any endocrinologist or physician, if they are part of the group, they would have seen lot of frozen shoulder patients, diabetic frozen shoulder patients in their practice.
I have one question. You have said sometime that repetitive movements may injure the capsule and ligaments. So exercise and repetitive movements, how would we advise on that? In old age especially.
Yes, sir. Yes, sir. So in elderly old age patient, if I have to say, repetitive movements is harmful more to, I come across many of the patients who are above the age of 60, 65, and they are playing very aggressive badminton.
Okay.
Not tennis. Tennis is okay, but they are playing badminton very aggressively. So those are the patients whom I warn that your rotator cuff is going to wear out sooner or later. Yeah. So that is to be avoided. And regarding the exercise, if you have seen one of my slides, your scapula. Scapula plays a big role in stabilizing your shoulder joint. So we focus lot of things on scapula stabilization exercises. So your upper back stabilization plays a good role in the shoulder health.
Okay. So this yoga exercises of doing this anterior posterior rotation of shoulders, and so it's a very routine exercise that we learn from in yoga. So that's okay, no? It's about jerky movements which are more harmful or repetitive movements.
It is a jerky movement which is more harmful. One. Second, the exercise which when patient comes in a consultation and when we explain you need to go to this physiotherapy, Satish bhaiye je mention કર્યું કે તરત જ પેશન્ટ આપણને કહે કે સર આટલી એક્સરસાઇઝ તો અમે મોર્નિંગ ગાર્ડનમાં કરતા હોઈએ છીએ અથવા અમારા યોગા ટીચર કરાવે છે. But as a specialist, what we see in our field is not only the movement, the strength of the rotator cuff, strength in each of the rotator cuff muscle, their scapular strength, scapular stabilizer strength. So we always advise them કે તમે જે કરો છો એ continue કરો. We don't say no. But you visit my physiotherapist, and this is a scientific way of stabilizing your shoulder. You learn it and then you do again on your own at your home. So it's going to be slightly different than a routine.
Yes, there is fine tuning of the way we do it. Actually, I have exercised because I experienced it because I had impingement syndrome. Then I knew that no, this is how exactly the exercise had to be done, not the routine ones that people do in the garden, as you said, in the morning.
Yes, yes, yes.
Any other question? So thank you, Dr. Jaimin. Thank you for joining Saturday Club for this excellent talk today. And we'll definitely have part 2 of this shoulder pathology sometime in month of May or June, whichever is convenient to you. So thank you all for joining. We meet again next Saturday. There we have a psychiatrist, Dr. Amrita, to talk to us on next Saturday morning. So we meet again next Saturday. Thank you all. Thank you.
Thank you.